Okay, great. So let's get started. Happy summer, everybody, and welcome to this month's Miami Global Brain Tumor Symposium. Just going to short introduction here while we get started. Just quick introductions. As you know, my name is Mike Ivan. I'm one of the brain tumor specialists here at the University of Miami, and I'm joined by my co-directors, Dr. Komatar, who's a professor and program director of our residency, Dr. Morko is professor and co-chairman, also director of our skull-base and cerebrovascular program, and Dr. Benjamin, assistant professor and director of our skull-base lab. It's our 38th session of our brain tumor symposiums, and we couldn't do it without the help of University of Miami and Sylvester Comprehensive Cancer Center and the Department of Neurosurgery and all of the administration that helps us each week. So thank you to all those who make it happen. If you have any more questions about tonight's symposium or about our future symposiums, you can always find us on social media or our website. All of the lectures get posted to YouTube, so you can watch them over again, and we've had thousands of views, I think, of people who have done that, so please take advantage of that. I also would like to bring to light some of the other symposiums that we have. One Monday a month, we have the Pediatric Neurosurgery Symposium. I know Dr. Ruck has already been on that one. We also have a Cerebrovascular Skull-Based Symposium. The next one's July 15th. It's going to be advanced skull-based topics with a great group of young and old neurosurgeons, which will be great to kind of compare and contrast some of the techniques that they'll be presenting. Next month on our symposium for brain tumors, we'll be welcoming one of my chief residents from residency, Dr. Sinai. He's now director of a brain tumor center at the Barrow, who's going to be talking about some new technologies in glioma surgery. So be sure to tune in then. It'll be an exciting talk. As far as tonight's symposium, please, participants, make sure you ask questions. We'll try to get to all of them throughout the night, but use the Q&A button. It's the easiest way to keep track. We don't offer CME, but you will get an email confirming your participation tonight. And please be sure to like, follow, and share our videos on social media, on the internet, so that we can continue to grow and share this amazing knowledge that we get every month. So this month, we have a great group of panelists. I actually have the pleasure of saying they're all our new brain tumor fellows here at the University of Miami. Dominique Higgins, who joins us from Columbia, Nitesh Patel, who joins us from Rutgers, and Dr. Cater, who's our old enfolded brain tumor fellow from here at the University of Miami, and they'll be discussing tonight's cases. For our special guest tonight, I'm sure if you have anything to do with neurosurgery, you know who Dr. Rutka is, world-renowned neurosurgeons, but we have a lot of international kind of people who participate every month. So let me just give him the due fact of everything that he's accomplished. He's a world-renowned pediatric neurosurgeon at the University of Toronto and acts as the R.S. McLaughlin Professor and Chair of the Department of Neurosurgery. He subspecializes in both brain tumors and epilepsy, and works primarily at the Hospital for Sick Children in Toronto. He has a brain tumor laboratory that's been extremely successful, a really tremendous physician scientist, and he focuses on molecular biology of tumor growth as well as invasion in brain tumors, and he leads the Brain Tumor Research Center also at SickKids. He's been the past chair of the Division of Neurosurgery also at Toronto. Academically, he's been extremely productive, over 500 peer-reviewed manuscripts. He's in 2014, he was named the editor-in-chief of the Journal for Neurosurgery, and just done a fantastic job at just raising the level of that journal to a great area. And while doing so, really kind of publicizing the importance of the journal, and also educating the young neurosurgeons, medical students, and residents on how to improve their contributions to academic neurosurgery. He's also co-edited several neurosurgery textbooks, including the one up here in the corner, Neuro-Oncology of CNS Tumors. He's acted as a past president for AANS as well as the Academy, and in 2019 was given the Cushing Medal at AANS, which is the most prestigious award given to a AANS member for his contributions to technology and innovation in brain tumors. So we really can't thank him enough for taking the time out of his busy schedule to talk to us tonight about a very complicated topic, and we're very grateful to hear from him. So thank you, Dr. Rutka, for your time.
Great, thanks very much, Michael, and thanks for the invitation. I must say it's a pleasure to be back in Miami. I've visited on several prior occasions, and this is the first time, of course, virtually. And I must say you're doing it right at the University of Miami, and what you've done for all of us during the pandemic really deserves mention and acknowledgement. So congratulations to you for putting on these virtual symposia, for bringing us all together, for providing information at a time of great need across the world. So fantastic, and I'm truly privileged to take part in the symposium today. So Michael, thank you. I know you through the journal. Nitesh I just met, and of course I know Jacques, I know Rick Komatar, and Alan Levy, many of you there. I won't name everybody, but thank you. And I thought what I would do today is speak a little bit about an area that's very interesting, at least to me, and it's going to be primarily a clinical talk today. And although Michael did mention that I do research, I'll have a little bit to say about the research, but essentially I'm going to talk about clinical cases and approaches to the brainstem, because this is very important, I think, for all neurosurgical oncologists to know about. So the title slide that you see here, and I'll just go to the screen. The title slide is actually a response or an answer to a question that was asked of me for my examinations as a neurosurgeon in Canada. We have a written exam, and it's not multiple choice. You have to actually draw diagrams and figures and things like this. The question was, at the level of the inferior collicula, draw the brainstem, draw the midbrain and all of its nuclei and pathways. And so think about that yourself and ask yourself that question if you could handle that one for an exam question. It was quite, a revealing question. Okay, brainstem tumors in children, also in adults, the same. Long thought to be inaccessible, but now we have all these great technologies and tools that we use to get there and to get there safely. But I will classify them to you according to their anatomical location. And since the era of MRI scan, this has become a lot easier. So midbrain tumors can be focal or tactile. Pontine tumors, diffuse intrinsic, dorsally exophytic, or focal or cervical medullary tumors as listed there. These are the smallest tumors known in the body that can kill you. These are called tactile astrocytomas, and they kill you not by their size, of course, not by their invasion or aggressiveness, but rather by the location within the CSF draining pathways. And so they're very slow growing, if at all, in terms of their growth rate. And CSF diversion is all that you need for most of these tumors. And these were first described by this fellow. This is Dr. Alex Sanford, who was a neurosurgeon in Mississippi for years and years. And he published this as pencil gliomas. That was the term that he applied to them first, but that was the first time these tumors had come to light in terms of their presence in the nomenclature. Here's a 3-month-old male, obstructive hydrocephalus. Back in those days, this is like 1990, before we had real great access to MR, or at least before surgery, then, we just placed the shunt. But nowadays we would do something, I think, a little bit different. And you can see on the MRI scan, thickening of the tectal plate here, and an occlusion of the aqueduct. Here's an example of a tectal glioma. You can see here, I'm pointing on my screen, and obstructive hydrocephalus. You can see here the flare signal change, in addition to some signal change in the thalamus, which is a little bit unusual. And this is a 10-year-old male who had worsening headaches and a family history of GBM. But we did ETV alone, and as you can see here on the arrow, a nice flow void is seen, and that's all that's needed by and large for these types of tumors. Another case of tactile astrocytoma, you can see the lesion here in the dorsal aspect of the midbrain. You can see it here quite nicely on the sagittal MRI scan. And this child had papilledema, so we did the same thing. We did an ETV, had a really good result, and she felt so great after the surgery. She went out and did trampolining. And because she had a pressure change with a gradient now from the ETV, she ended up getting an acute epidural hematoma that you can see there that was managed conservatively. But you have to be careful in the postoperative period in some of these patients. Another case here, 8-month-old. And this one I'm showing you not because there's a tectal glioma there, but rather there can be very subtle changes in and around the tectum. This is a web that's seen in the region of the aqueduct, and that required a ETV, and this patient did extremely well after that. So I know this is very routine for all of you. You've learned how to do this, endoscopic third ventriculostomy, but this is a very nice video that shows you beautiful anatomy. You see the dorsum sella, you see the pituitary stalk, you see the basilar artery there. Beneath the basilar, of course, is the brainstem. You have to be very careful so as not to injure the fornix when you're using endoscopic techniques in this area. In this particular strategy, a coagulation is made on top of the the dorsum celli that you can see there, and then we'll use a technique to expand this, and then a balloon technique afterwards that you'll see. So there are many different ways of doing this. I've seen folks use the laser. I've seen sharp instruments inserted. Here's a balloon that's showing you how to make the ETV, but you actually always have to see the basilar artery. Here's another currently applied techniques where using a stylet, we make an opening and then essentially spread that with a endoscopy forceps, and then that allows you to penetrate that space, but you have to see the basilar artery without an arachnoid web over it in order for this job to be done completely. So this video is showing you another technique. I showed you the balloon technique on the previous slide. This is a spreading technique. You can spread in different directions, usually at right angles to each other, so that you can get the largest stoma possible. And it's a fairly safe procedure. There are very few complications associated with it. Sometimes tectal lesions are quite large, as in this case here that you see. And these, you're not going to get away just with doing an ETV. So sometimes you need to operate on these types of tumors. This patient had a Paranode syndrome, so limitation of upward gaze. And this is the post-op. You can see pre-op, post-op, and what we did was a open procedure, showing a video here of that. We've opened up into the cyst now, and we've done a removal of the cyst wall by carefully using dissectors to bring the cyst wall in and removing it like that. This was a pilocytic astrocytoma in a child who had NF1. Not all of these tumors are gliomas. Occasionally you'll get a tumor looking like this in the tectal area. So this is in the tectum, it's not in the pineal region. So 18-year-old, headaches, amenorrhea, papilledema. We did an approach here using image guidance, open occipital transtentorial approach. There's an image from the surgery. This was germ cell tumor, so germinoma. So you can think that some of these are gliomas, and you might actually make a mistake if you don't get a tissue diagnosis on some of these lesions. Many different approaches to the tectal region shown here. You can be familiar with many of these, as you can see. Occipital transtentorial was mentioned on the previous case, supracerebellar, as in this case, and subchoroidal approaches. There can be retrosplenial, several, subtemporal, many different ways of getting there. I'll just bring your attention to this in Neurosurgical Focus in the July issue. Great videos for you to see on pineal region tumor. This is not exactly the tectal area, but it's pretty close, right? So I've asked you to go and take a look at some of these videos. It's really fantastic. And there's a new website on the journal that will take you to these various different video segments. Okay, and then this is really interesting situation. Before and after ETV, you can see the change in the size of the ventricles. A case report series that I put together with Rick Boop several years ago. This patient had an enhancing tectal mass, and then the only thing we did was surgery, ETV, and the mass kind of went away. The enhancement went away completely. We can't explain it. We don't know what it represents. We didn't biopsy it, so we couldn't actually prove what the pathology was, but an interesting finding after ETV only, and no further therapy was required. Okay, let's move next to focal midbrain tumors. And these tumors are very challenging. They're located here, you can see on the schematic. Focal enhancing, involving typically the tegmentum of the midbrain, hemiparesis, upper cranial nerve palsies. And many of these will be amenable for resection. So years ago, from our hospital, sick kids, Dr. Hoffman and myself and others put this series of patients together. This is a archival video from when Dr. Hoffman was operating the either late 1980s or early 1990s, entering, and he's done a subtemporal approach here, and he's using the cavitron in the brainstem to resect this midbrain tumor. So this is going back, many 30 plus years, and showing that we were operating even back then on these tumors. More contemporary case, 9-year-old, hemiparesis. You can see the lesion is within the midbrain, but has a cyst associated with it. Image-guided resection. We used the middle temporal gyrus approach. It was a pilocytic astrocytoma. there's the end result, and it's done extremely well. But image guidance, yeah, I think it's fairly important for a lot of these cases, and I would encourage you to think about having this definitely on board as you're doing resection. Here's another child, 6-year-old, with this very, significant lesion in the midbrain, third nerve palsy, left-sided hemiparesis. A biopsy was done stereotactically at first that showed low-grade glioma. So we elected to resect this transcallosally, as you can see here. And you can see where the crosshairs are here at the bottom. That's the depth of our penetration with the interhemispheric approach, a long way down, and having the cavitron way down there. But there's the pre-op, and there's the immediate post-op. And then here's the many-year post-op, 7 years. Surgery was all that was done. Of course, the biology is on our side. This is pilocytic astrocytoma, and this child has done exceptionally well, graduated, and is off in university at the moment. A 12-year-old with this lesion in the midbrain, right hemiparesis, as you can see here, and papilledema. And this is the resection afterwards, showing the extent of resection, some hematoma in the area of the resection cavity. Pilocytic astrocytoma. So many of these will turn out to be pilocytic astrocytomas that you can see here. 10-year-old, right hemiparesis, otherwise was intact. There's the lesion on the sagittal, pretty formidable lesion. We chose a mid-temporal gyrus approach here. There are many different ways you could approach this. You could have done a trans-sylvian, splitting sylvian fissure approach to get here. And here's the immediate post-op. This child did extremely well. No significant worsening in terms of neurological function. Went on to get some chemotherapy for this residual and has been stable since. Another lesion flipped over on the other side here. You can see in this child with the question of the diagnosis, NF1, autism, 10-year-old, brief history. We did all of this, turned out to be low-grade glioma, and there's the resection. So again, coming in this time in middle temporal gyrus, but again, several different options for you to consider approaching these lesions, but have navigation available, know your boundaries, use intraoperative neural monitoring, and you can really do a major resection on these cases, and the children do well. And based on the pathology and the molecular biology subsequently, they may be candidates if there's residual for chemotherapy that can be tried over the course of time. Okay, the next tumor is diffuse intrinsic pontine glioma, and this is one that unfortunately we don't have a surgical solution for. These patients present with cranial nerve palsies and long tract signs, and usually they're quite young. Hydrocephalus occurs late in the course of the disease, and they're all anaplastic tumors. The survival is less than a year and a half. Here's a 14-year-old. Open biopsy was performed for this. Is a little bit atypical. First of all, the age is a little bit atypical. There's the lesion you can see in the brainstem. Doesn't take up the whole pons, but we decided we'd do a biopsy under ultrasound guidance. Yeah, I'm sorry it didn't come through on this one, but you can see here, survived 24 months. We found the diagnosis was anaplastic, and this child, of course, suffered the end result, as many of these children do. So the question is, do you biopsy or not? Now, nowadays, especially in North America, more biopsies are being performed. This is from the French series from the Necker Institute in Paris, where they did biopsies of over 130 of these types of lesions. And here's a 16-year-old male. Again, atypical presentation for age. He happened to be an avid hockey player, and he underwent radiation therapy and chemotherapy. We decided in this case not to do a biopsy, and sadly, he passed after about 18 months. So this is a little video, a little bit of propaganda from the University of Toronto for you on one of our discoveries related to the genes involved in diffuse intrinsic pontine glioma.
Out on a deadly form of brain cancer. DIPG affects children and teens, and over 90% of those afflicted die within 18 months of being diagnosed. But as Stephen D'Souza explains, researchers in Toronto say they found a genetic clue about the disease.
This is on our trip to Dominican how we went down after we had just gotten the diagnosis.
Stan and Marisa Bertoya haven't changed their son Daniel's room since his death 6 years ago. At age 16, Daniel was diagnosed with a rare brain tumor and was told he had less than a year to live.
Losing your eyesight, losing your hearing, losing your speech, losing your mobility, basically just devastating to see your son going through that.
His parents scoured the world for help, but found no effective treatment.
We hung on, to every little thing that we could possibly hang on to, but really there was nothing there.
Before his death at age 18, family and friends organized fundraisers, and Daniel had one wish for the money.
He said, "Dad, I want it directly to research, so I'll find a cure."
And this big white blob in the middle is the tumor.
Daniel's type of cancer, known as DIPG, is diagnosed in a few hundred young people in North America each year. Located on the brainstem, it's inoperable and chemotherapy is ineffective. But using new technology, researchers at the Hospital for Sick Children discovered cancer genes they hadn't seen before.
The genes mutated in this cancer are completely different than what we see in adults. And so we cannot use the same drugs as what we were using in adults.
That told them they needed new and unique treatments.
We can go to somebody with this diagnosis, and rather than it being a death sentence, maybe there's some hope that some chemotherapies are going to work now.
While that's still years away, after raising more than $500,000 for research, Marisa and Stan are happy to see progress.
To get this little baby step right now, it's just amazing, and I'm hoping that it'll turn into giant steps one day.
His favorite player.
They say this gives them even more motivation to keep raising money and awareness to help fulfill their son's final wish. Stephen D'Souza, CBC News, Vaughan, Ontario.
Yeah, so I know Tampa Bay's in the finals of the Stanley Cup playoffs along with Montreal. So a Canadian versus American match right now. So we'll see how that all plays out in the next game or so. So the genetics of these tumors, kind of shown on this slide here. In this one from Cynthia Hawkins is from the Toronto group. ACVR1 mutation, I'll speak about that in a moment, but 4 papers published simultaneously in 2014 on this, and many good review articles now. I'll just refer you to. This is one that we published a few years ago, showing the molecular players that are involved in DIPG. And the more recent one here, anyone interested, I can send this to you, but showing now that the types of epigenetic and genetic changes that are involved and that are steering us in the direction of some types of chemotherapy over others. And everything you need to know about DIPG is found on this single slide. I'll just leave it up here for a moment so you can take a look at it, but everything from prognosis down to ongoing clinical trials is here. And it's summarized in that clinical review that was on the previous slide. But all the current genetic mutations that we know of are listed here and so on. So as I said, if you're interested, just to email me, I'll send it to you. So lots of work in clinical trials over the horizon, but nothing so far has worked. Why has there been no effective treatment with this disease? Well, it might be because the drugs that we're using aren't just getting to the target site. Most of these lesions, as you know, are non-enhancing. So the blood-brain barrier is intact in the brainstem. So it might be that we can't get the chemotherapy across. So Mark Swadan from New York has been using convection-enhanced delivery, a technique I'm sure you're all familiar with, as a means to try to treat DIPG. And he's had a number of clinical trials, and they're looking promising. We chose to look at MR-guided focused ultrasound for DIPG because of its potential for overcoming the blood-brain barrier and delivering chemotherapeutics across it into the brainstem. We had an experimental paradigm that we used in mice, and we were able to do a high throughput drug screening, and we found a number of candidates that looked interesting, one of which was doxorubicin had never been used before in this tumor, and it was the most sensitive of all the drugs used. And in our animal model, you can see we can increase the amount of doxorubicin in the brainstem when compared to the brain by using MR-guided focused ultrasound. So very interesting technique. And we published this just a few years ago as a proof of principle, but not with a tumor model. This was in a normal brainstem model. So we then developed a brainstem model of DIPG, and we had the RCAS model that we used, a genetically engineered model, but also an implant model, a xenograft model. And the xenograft model actually turned out to be better for us in terms of our studies. And this is the schematic that shows the workflow for MR-guided focused ultrasound in this animal model. And we were able to do this, implant a tumor, and then treat the mice with MR-guided focused ultrasound. And you can see that we could increase the concentration of the doxorubicin in the brainstem as calculated by mass spectroscopy, able to do that quite nicely. After we had done the treatment, the Ki-67 index went down, and our early animal survival studies are showing us that we are getting an advantage. So we published this recently in the Journal of Controlled Release this past year, and that led us to develop this clinical trial. Those preclinical data enabled us to put together this clinical trial, and we're hoping to enroll our first patients either late this summer or early in the fall. And I know at University of Miami, you have MR-guided focused ultrasound. I've been speaking with John Ragab about it, and that you may or may not want to be a part of this clinical trial going forward. We're in the process of enrolling other centers to join us in this strategy. Okay, the next tumor type is dorsally exophytic brainstem tumor, shown in schematic here. Slow-growing tumors, long-standing symptoms, cranial nerve palsies, and these are tumors that you can operate on, unlike DIPG. And these are frequently resectable, and so we recommend not rating these up front. And if they recur, you can operate on them again. And most of them turn out to be low-grade gliomas. And that individual I was showing you there was Dr. Harold Hoffman, who was a very famous pediatric neurosurgeon from Sick Kids Hospital. So here's some MR features of these dorsally exophytic tumors that you can see here. Sometimes you can distinguish those from other types of cerebellar tumors like cerebellar astrocytoma just on the basis of the MRI scan itself. Here's a 14-year-old Jehovah's Witness, ataxia, headache, papilledema, extremely vascular tumor arising from the brainstem. We did a near total resection. Here's the lesion shown in the pre-op setting. Post-operatively, whenever you see a lot of blood like this on the post-op MRI, means that the surgeon's had a hard day because there's been a lot of bleeding and it goes retrograde through the aqueduct. And so this child had a stormy course afterwards, had a number of cranial nerve palsies, most of which resolved, but she was quite ataxic and had a swallowing disturbance and took a long time to get back on her feet again, but finally did. Now here's the post-op showing a very nice result, just surgery by itself. I have permission to show the child. This is on her graduation from Sick Kids Hospital, and she has done extraordinarily well and has gone off to university. Okay, the next tumor type is Focalpontine brainstem tumor, newly recognized group of brainstem tumors. You can see quite clearly here on the CT scan what some of these tumors look like. Maybe they'll be benign, some of them, but often they'll be anaplastic, but you should consider operating on these, especially if they present to a peel surface. Here's some further examples of these. This is a pilocytic astrocytoma, and the approaches to these tumors usually require lateral approaches to the brainstem, and there are many different ways to do this, and skull-based approaches have helped us enormously get to these locations. Here's one, you can see right-sided Focalpontine tumor, 7-year-old, recent history, and there's the lesion that you see. We chose this approach, which was a retrolabyrinthine pre-sigmoid approach that you can see here in diagrammatic form. The nice thing about approaches like these ones is that you can avoid brain retraction, right? You're basically letting the bone and bony removal do the work for you in terms of the exposure. And so we did that approach here. We've landed on the lateral surface of the brainstem. You can see cranial nerve there, 7. And we've done the approach, and we've had a really good opportunity to do the resection. The wake up was uncomplicated. He did extremely well, but unfortunately, this turned out to be an anaplastic tumor, and he received radiation therapy for it and survived about 2 years afterwards. Okay, the final brainstem tumor type that I'll talk about is the cervical medullary brainstem tumor, as depicted here schematically on the sagittal. You can see it, and I'm bringing Dr. Fred Epstein to attention here because he was the first, I think, to popularize this particular tumor and to instruct neurosurgeons that these are tumors that we can operate on. and he had a large series of these tumors. He relied heavily on intraoperative neural monitoring, and he was one of the first to use that routinely in the course of these types of tumors. And they can affect the high cervical spinal cord and the medulla simultaneously. Typically low cranial nerve dysfunction and long tract and cerebellar signs. This is kind of what they look like at the time of surgery. You can see swollen cervical medullary junction here. Typically, we do posterior fossa craniotomy, laminoplasties, midline myelotomies, and cautious debulking with neural monitoring. This is a instance where I think the neural monitoring is indispensable. You almost always should have this available if you're planning to tackle tumors like this. And so here we are with neural monitoring. We have great intraoperative monitoring at Sick Kids, and so every cranial nerve can be monitored, brainstem can be monitored, and we're very fortunate to have that scenario. I suspect you do too at the University of Miami. Okay, this looks like a formidable lesion, cervical medullary brainstem tumor, 14-year-old who presented with recurrent pneumonia. And it's not uncommon for these patients to have many admissions to hospital before somebody thinks to order an MRI scan, because they're presenting with other things at first. And so the diagnosis can be delayed. Hoarse voice, 12th nerve palsy, nystagmus, ataxia. Here's the lesion at the time of surgery. There's the magnified view, midline myelotomy, opening, cautious debulking, neural monitoring. And there's the post-op result, what it looks like. And here's the post-operative scan. You can see a very decent resection. Kyphosis can happen in the post-operative period. And so many of these children might go on to require some type of post-operative stabilization. The other thing to mention too is that many of these types of tumors turn out to be gangliogliomas in the cervical medullary region. And that's fairly good news, because it means that they can be beneficiaries of some chemotherapy down the road as needed, or if it's really required, radiation treatment. But that wouldn't be our first treatment choice. Okay, and here's just a real-time video to show you cervical medullary brainstem tumor. You see, of course, the cerebellum is up here. Now doing our midline myelotomy and opening up. Identifying, if possible, a tumor plane cautiously, then doing biopsies, and then you'll see the cavitron come in and do some work for us. And doing this carefully, stepwise, with the monitoring as mentioned. The tumor can be exposed, and then the lesion can be debulked in large part. And there's the cavitron in view. Again, let the tumor come up to you into the cavitron. And then you'll see we'll be opening up more superiorly here into the medulla. And while we were doing this, the debulking, we got intraoperative monitoring changes, motor evoke changes. So we decided at that point, having done a decent resection more rostrally, to hold off on further. You watch, you wait, you use cold saline, you watch what happens to the return of activity of your monitoring. And you go to a place where you're not getting any changes, as we were here. This is more caudally, and that's the final view. So just a video demonstration of some of these tumors. Yeah, I'm sorry. I'm sure you're seeing that I've got a blank screen here. I don't know what happened in the transfer of materials in this scenario, but here's the video. This was a child who had a cervical medullary brainstem and represented with cystic changes that we went back and drained the cyst for, and she had a really good response to that, and she's done extremely well. There's the post-operative view inside the brainstem that you can see there, and she's done extraordinarily well. And there's the image, and there she is, having, again, permission to show her image. She's also graduated, gone off to university without needing radiation treatment. So at sometimes these tumors turn out to be a chronic disease, and they can go on, they can smolder on for some time, and many different trials of chemotherapy can be utilized. I didn't prepare slides today to talk to you about the chemotherapy for low-grade gliomas, especially in the brainstem in children, but this whole field has advanced enormously with a variety of targets. The BRAF gene, for example, is often fused in this particular tumor and others in the brainstem, and can become a target for focal chemotherapy that's targeted. Many MEK and MAP kinase inhibitors are often used for these types of tumors. A 6-year-old had debulking years ago, then went on to have a couple of subsequent surgeries, ganglioglioma. As they progress and as they do grow and as they infiltrate, they can become G-tube and ventilator dependent, as this child was. So I don't have a picture there, but he wrote a book on his experience having had a brainstem tumor and having been on a ventilator and so on. And as I said, can be a chronic disease in many cases. This is a report from the group out of St. Jude's. So Rick Boop's name is here, Paul Klimo's name is here. And their tumors are very similar to the ones that I've shown you already today for this disease. And there's the survival curve. So it's not as good as some of the others that we talked about today, but it's still not bad. It's not, and with chemotherapy now arising, some of these tumors, some of these patients can do extraordinarily well over many, many years, decades, for example. So surgery can provide stabilization of the disease. If there's progression, you can consider either chemotherapy or radiation therapy, or you can come back and do more surgery. Cervical spine instability can lead to stabilization efforts that are necessary. So spinal fusions may be necessary. I mentioned a bit about the BRAF mutations and other types of targeted chemotherapy, again, with the MEK and MAP kinase inhibitors being helpful for these types of cases. So here's a case when we decided not to do aggressive resection, but rather very limited resection. It was coming out of the medulla that you can see here. And this is after the surgery, still considerable residual left behind, but after chemotherapy, this virtually went away altogether. And this child went off to university and has done extraordinarily well, is pursuing medicine as a career path in her life. Just to show you that radiation therapy is not used up front for all the tumors I talked about, with the exception of DIPG. And we published years ago what happens in some cases where you use radiation therapy in some of these tumors and the development of anaplastic change, which perhaps could have developed on its own spontaneously, but may have been expedited by the use of radiation therapy, especially in children that have NF1. We've learned not to use radiation therapy for kids with NF1, with low-grade tumors. So just reserve radiation therapy, be cautious about using it. I know the pediatric neuro-oncologists are very wary of using radiation therapy for any kind of low-grade tumor, whereas it was used when I was starting my practice in neurosurgery 30 years ago. Radiation was a standard therapy for these tumors, but not so today. Okay, so we're going to wrap up and summarize these. These tumors can be classified according to the tumor types based on anatomical location. Surgery has a role to play in many different tumor types, as I mentioned to you. The neurosurgical approaches are based on tumor location. Navigation, monitoring, I mentioned, are really important. And now chemotherapy can be targeted towards the main genetic defects that are identified within the tumors themselves. So when to operate, when not to operate, that's always a good question in neurosurgery. The plus signs means, yeah, this is a good place to operate. The negative or minus signs mean, be wary of operating here unless you're doing a biopsy, of course. And, these give you good indications as to when to think about doing surgery in these particular cases. So just remember the classification in these brainstem tumors in children: midbrain, pontine, and cervical medullary tumors. And with that, I'll conclude. This is Sick Kids Hospital, and we're one of the main pediatric players for neuro-oncology across North America. So our experience, I was very pleased to share with you today. Be very happy to answer any questions that you folks may have. Thanks very much.
Thank you so much. That was an amazing whirlwind of all the possibilities of treatment and approaches and pathology in the brainstem. I had a couple questions for you though before we start with, for the midbrain reasons, you showed a lot of the tumors that were close to or involving the cortical spinal tract. I was wondering how much to use intraoperative mapping for some of those tumors, especially in kids, and is it effective or not?
You're talking about the midbrain tumors, Michael, I think, was it? Yeah.
Yes.
So, yeah, we would do, as mentioned, intraoperative monitoring. We use the trains of 5 technique on the cortical spinal tract, right? For being able to get like continuous mapping throughout. And then as we're getting like deep inside the cavity, and these lesions are quite deep by the time you get to them, we can use the subcortical stimulating device if we have any questions about where the plane is between abnormal and normal, brainstem. So a combination of the mapping that we use and the subcortical stim will, I think, try to keep you as safe as possible for the resection of these lesions.
And then for the pilocytic tumors, what do you do with the capsule? Are you pretty aggressive with that, or you just take out the the solid tumor part?
Yeah, I think, if you were in a situation where you had a well-defined capsule, and they mostly occur, Michael, in the cerebellum, right? And those can abut the brainstem, but if they're those types of tumors that have a well-defined capsule, and let's say a cystic element associated with them, it's been shown time and again that frequently the enhancing capsule, if it does enhance on MRI, will contain tumor cells. So we try to go after those enhancing capsular elements. But if it's non-enhancing, I'd be inclined to leave it alone if it's in a deep critical part of either the brainstem or the cerebellum. If it's hitting the deep cerebellar nuclei or something, I'd probably leave it behind if it's non-enhancing.
One of the questions with since you have now some more experience with the focused ultrasound, I was always concerned with some of the newer, I guess, machines with the proximity to bone, and that's how accurate and how much effect do you lose, I guess, when it's close to that. With brainstem lesions, is that something that you're concerned about? I mean, I'm sure you're going to be looking at it in the clinical trial, but what are your thoughts on that?
Yeah, no, it's always a concern about, the reverberation when you get close to the skull base with focused ultrasound. So we were able to pull this off in the animal model I showed you, and that's a much smaller target than what we're going to be dealing with in the human case. So I suspect that we'll be able to work our way around this and be able to handle and navigate through the difficulties with the bony skull base, which is adjacent to the brainstem, as you mentioned. And we're really hopeful that we'll be able to get the very fine, sophisticated, and accurate localization of the focused ultrasound, and then allowing for the transmission of the chemotherapy into the area of most need by virtue of having worked out the details and the coordinates of the focused ultrasound in humans. So this will be the first in man study, and we're hoping, as mentioned, to start this up in July.
And Dr. Shelley Wang, one of our pediatric neurosurgeons, is asking about, is it only going to be for DIPG, or is it going to be for all tumors of the brainstem or deep brain tumors, or are you just focusing purely on DIPG in the first iteration?
Yeah, thanks, Shelley, for the question. Yeah, the question and the answer to the question is really just at the moment for DIPG. We're not thinking about using it at this stage for other types of tumors, and our protocol is set up just for DIPG. Doesn't mean that it can't be used. At the University of Toronto, our adult neurosurgical oncologists are using it for METs and GBMs now with breakdown of the blood-brain barrier. But for the kids and for our series of cases, we're planning on just keeping it confined to DIPG.
One of the questions here by somebody called Alim Baramov wants to know a little bit more about what your thoughts are on why these tumors kind of occur in this location in the brainstem, and why do they not spread to other areas of the CNS or outside the CNS? Just kind of your overall kind of thoughts maybe on that topic.
Yeah, I would say that mostly they are confined to the brainstem, as you had mentioned. On the other hand, when, for example, DIPG is late in the course of disease, it will definitely disseminate along CSF pathways, and you'll see involvement of the leptomeninges in the spine and other parts of the brain. So that clearly can happen. And then, curiously, even benign tectile tumors, they can metastasize. And years ago, we published a case report, and there have been other reports published on low-grade tumors, pilocytics even metastasizing to distal places. And it's hard to know exactly why that is, what the biology of those tumors indicates. That's a rare situation, but sometimes they will spread outside even the brainstem for these types of typically focal tumors.
And while we get one of the fellows here ready, Dom, do you want to maybe present while I ask the last question here?
Yeah.
Get your slides up. One other question was, we have a lot of literature on extended resection for low-grade tumors. And I want to know your thoughts on how that extends into the brainstem and some of these tumors that kind of are expanding out into the peduncle or the cerebellum. Is there any role in taking out some of the safe areas of these tumors if you don't think you can take out the brainstem part, or just biopsy is always kind of the first thing that you start with?
Yeah, thanks, Michael. I mean, yeah, there's it's interesting how the notion and the world has changed in terms of our philosophy on what to do with these low-grade tumors and extended resection. I still think that do no harm is very appropriate adage at this stage, and try to keep yourself as safe as possible. But try to push the boundaries as much as you can. But the worst thing to have happen is pushing the boundaries, having a tumor in a critical location like the brainstem, like in the midbrain, like I showed, causing a neurological deficit that's going to be lifelong and permanent, and leaving residual tumor behind, right? So
Right.
You don't want to have that scenario. So where possible, follow those principles, and it'll hold you in good stead.
Okay, great. Thank you so much. Dom, do you want to present your case?
Yes. But for Dr. Argo, thank you for a great talk. It was a great overview, as Dr. Ivan said. Before I had a couple of questions for you before I share my case. With regard to biopsying or not for DIPG, what's your kind of metric for whether or not to pursue one, especially with the role of histone mutations and other markers that may impact therapy? And then along those lines, what role do you think sampling, I wouldn't say error, but heterogeneity plays in the role for these tumors?
Yeah, thanks. That's a great question, Dom. So we were really hesitant 20 years ago to biopsy any of these, and then techniques became available to do this safely, usually using navigation and stereotactic techniques. But it didn't really change anything in terms of what you were going to do for the patients. But now, as I mentioned, with the opportunity to do molecular genetics, you can classify the DIPGs into those that are going to be living a shorter time versus a longer time, and also studying their genetic mutations in detail that might have clues to new therapies that haven't been tried before, if you're in a center that does that. And our center in Toronto, we do whole genome sequencing, we do the epigenetics, we do all of the single cell testing on the tissues that come our way. So we get that information, and we're in a situation where we can use that. So we think then biopsy is going to be important, even if it's a standard presenting DIPG that looks like all the world, like all the DIPGs that you've seen.
Yeah.
We'll still do biopsies just so we can get that information, because we might learn something from all the genetic testing that we're doing at our center.
Okay. I'm going to show a case. It's work from my time at Columbia doing my research period. One of the projects I worked on is we partnered with an industry and our pediatric hemoncologist, Sturgis Zacharioulis, and Dr. Felstein, our peds neurosurgeon, Dr. Bruce, to get this trial off the ground, similar to Dr. Swedane, but using convection enhanced delivery for DIPGs. And we're nearing completion now. We're able to get the IND through the FDA during my research time, and thankfully it's wrapping up. And just showing an example here on the right of the T2, you can see the hypointensity is the catheter placement with the biopsy track medial to it. And we do an internal delivery system of this novel formulation of an HDAC inhibitor, penobinostat, and you can get good coverage throughout the pons in the region of the lesion. And there's also interest in focused ultrasound at Columbia as well with Fred. My question for you in designing trials that look more at efficacy though, like how do you study the effects that you're getting? Because in the mouse you can take the whole pons at the end of the study and you can look at drug levels.
Yeah.
What's your picking your brain here? What's your thoughts in terms of monitoring efficacy for these trials? Do you do repeat biopsies? Do you think it's safe, or you try to do systemic markers to check in?
Yeah, so these types of studies are slow to get off the ground because, first of all, there's not like huge numbers of patients, and secondly, what we have to do is we have to show safety first, right? So I have to prove our study is kind of safety and then efficacy. So safety, enrolling 3 patients with a small subset of the pons being broken down for its blood-brain barrier, another 3 patients where a larger section is going to be looked at, and then another 3 patients where the whole pons is going to be targeted. Okay. So, that's going to play out over the course of a year or so before we get that safety information by itself. And then we can ask the question about efficacy subsequently. And, we can't interfere with what's considered standard therapy right now. And standard therapy for DIPG is radiation treatment. So our kids are going to be getting radiated first, and then we're going to be coming in with, the focused ultrasound. So that wasn't, our preference, but we could not get it through our research ethics board unless we followed standard therapy and then added this on top of it. Yeah. So then you have to ask the question, probably you need to do this de novo before radiation therapy, if that's possible. And so that's going to take some time too. So it's just to show you that all these things are going to play out over the course of, probably a couple of years or more. And the more centers that we can encourage to take part in this, and the more centers that have MR-guided focused ultrasound, I think the better it'll be for all of us in terms of moving this field forward.
Great. Thank you.
Okay, thanks a lot.
Thanks, Tom. Natasha, you want to go?
Hey, sorry, it's trying to figure out how to unmute myself. Dr. Rucker, that was a great talk. I think especially for myself, who's sort of obviously still in training as a fellow, is sort of finding an organized way to think about this, as opposed to just looking at it as a grab bag entity, is kind of nice. And I really appreciate your presentation on it. And once again, thank you for joining us on this conference. I have a case that we actually saw here in our tumor board last week. It's actually my first tumor board as a fellow here, so it's kind of interesting to see. It's pretty quick. I have a few slides, so I'm just going to get started with that.
Yes, I think you're muted there, Nitesh.
It kept muting me out for some reason. I think I'm back on now.
Okay.
So it was a 61-year-old female who had presented to an outside institution in Romania, actually, back in February of 2020. She presented with dizziness at the time, and I think some other symptoms as well, which led to an imaging workup. The details of her visit are a little bit spotty. We have some untranslated documents from Romania. But at the time, they noted what seemed like a pontine lesion per description. We don't have any images from there. It was presumed to be a glioma. There was no biopsy or anything done. However, it was treated medically with 54 Gray 28 fractions and 2 cycles of TMZ, which ended back in December of 2020. So, a little less than a year after initial diagnosis. Again, no biopsy was done. And then she ended up in the States. Sort of lost a follow-up to her primary sort of providers that had seen her in Romania, and presented to us, to our neurology team, with left hemiparesis. Had a new MRI done, which we could only compare to prior reports, and showed an expansion of the known lesion from the prior reports. See some axial images. The leftmost image is a non-con axial T1 image. And again, you can see on the right side, in the sort of pons area, then going off into the brachial pons, you can see there's an area of hypointensity, and then it does contrast enhance on the serial images towards the right. And these are sort of staggering up, and each cut advances. And then I have some more views here as well. Here's a coronal view, T1 plus, a SAG, and then a T2. Now, this woman at this point, she hasn't had any further treatment. We talked about our tumor board, and I think ultimately this is more of an open-ended question, but we talked a lot about pediatric patients, but when you have an adult in this scenario, we're sort of left in a 61-year-old, so it's like perplexing situation. Where do we go from here? She's received some sort of empiric treatment, so to speak, for a presumed diagnosis. This is what this is the entity we're facing with here. So, what's your thoughts on it?
Yeah, thanks, Natasha. Yes, it's a tough one, right? Because you don't have all the history you'd like to have from before, and it sounds like the time interval from the radiation that was previously given to today, is that 2 years roughly, or how long, or do we know, like when?
So it seems like the treatment ended in December of 2020, so we're probably approaching at least half a year,
Okay.
If not more.
Yeah, and becoming symptomatic. This is sort of patchy enhancement, but the brainstem is really swollen, as you can see here. Like, I don't think this is going to be good news for this patient, but it probably is worthwhile to do a tissue biopsy or tissue diagnosis for sure. And how you go about doing that, you can choose any one of a number of ways. Probably the easiest would be stereotactic biopsy, but you could also approach this open if you were worried about that, and a number of different ways to get at this area. It seems like the enhancement is kind of ventral and lateral off to the right side, if I'm reading this correctly. So so I mean, you could do like a subtemporal approach. You can see on your coronal there, you could split the tent and you could be right there, which, if you were interested in an open approach. But probably you get the information you want from a stereotactic biopsy or robot guided biopsy, something like that. And I think I would recommend that, because I otherwise you're not going to know what you got here, and the safety of that procedure is pretty respected nowadays. A lot of series on brainstem biopsies in adults and in children with acceptable morbidity. But I don't think this one's going to end well, given the symptoms that you're describing that are new, and the progression and age, and the fact that radiation, this is a pretty recent change in neurological status after radiation was completed in December.
Yeah, no, I think we sort of felt the same way during our tumor board discussions. There was questions about getting some more imaging, perhaps a SPECT scan, but I think we had talked about doing a potential biopsy as well, and I'm sure we'll bring her back up in our tumor board coming up.
Yeah.
Are you doing most of your needle biopsies kind of through the peduncle, or do you come the longer approach, transfrontal and kind of?
Yeah, I've done it always. Posterior fossa base, sort of middle cerebellar peduncle approach. I've come far frontal, heading posteriorly. That's worked out really well. So you just try to decide what the best trajectory is, and also with your knowledge of the brainstem, avoid regions where there's sort of high stakes.
Okay, great. Mike, do you want to give your case?
Yep. A second. Thank you again for taking the time to talk to us. It was a really great summary of all the different surgical considerations for each of these tumors. This case I came up upon was pretty interesting. So 35-year-old male with no significant past medical history presented with worsening dysphagia and instability with multiple falls. On exam, grossly neurologically intact with no focal deficit. You can see on the MRI here, he's got this large cystic lesion with a nodule enhancement. Working diagnosis was hemangioblastoma at the time. But in terms of the surgery was pretty complicated in that we did the suboccipital craniotomy, the cyst was decompressed, and the tumor was visualized, but as soon as any attempt to move this tumor caused the patient to either become severely bradycardic or to the point of asystole. So not sure if you've stumbled upon this at all during, I know you talked about, motor MEPs and SCPs, but, in terms of, cardiac hemodynamic instability, what pre-op anesthetic considerations do you have? Do you do transvenous pacing?
Yeah, well, thanks. This, Michael, this is a really tough case. I also thought at first it might be hemangioblastoma, but it doesn't really have a peel. I don't think it reaches a peel surface, so it kind of goes against it for that reason. But in any event, it still could be something like an astrocytoma, glioma, ependymoma. It could be a variety of different lesions, and your approach was exactly what I would do. But I must tell you, as a surgeon, I hate it when there's all these cardiorespiratory changes that occur that you're informed of by the anesthetist when they happen when you're operating, because that's nothing will give you pause in a greater way than hearing that from the anesthetist and hearing the heart monitor and everything changing. You have to be very safe in this region and location. You have to pay attention to the cues that you're getting from your anesthesia colleagues and what is safe to do and what isn't. So you're showing a couple of reprints here from titles from articles. Personally, I have not done transvenous pacing. I wouldn't have prepared for that up front in this particular case.
Right.
But I wondered if you were able to do a biopsy and what did it show?
So they weren't able to do a biopsy at the time, but interestingly enough, so the patient did well postoperatively. His dysphagia improved, his walking improved, just most likely from the cyst decompression. He was initially referred to radiation oncology, but after discussion in tumor board, radiation wasn't deemed an appropriate. He wasn't deemed an appropriate candidate for radiation. So they went to get a second opinion. This was a 2-month post-op MRI. You can sort of see that this cyst fluid is now reaccumulating, and he actually underwent a second surgery for resection. And this time, for some reason, when they went in, there was no hemodynamic instability, no bradycardia.
Yeah.
They were able to get gross total resection. I can play this brief video, just on when they did the opening myelotomy.
Yeah.
Was wondering, maybe it was stretching the fibers from the cyst that caused him to be more sensitive to these maneuvers versus but yeah, so this is his post-op scan. He did really well. No issues since then.
Yeah, no, that's great. I mean, I think that you have to weigh everything in balance, and some surgeons might have shied away from re-exploring, but it's fascinating that the second surgery was done and there wasn't the same issue with respect to the cardiorespiratory changes. So it may be related to just the rapid decompression of the cyst, and maybe that had done something to the critical and vital centers in the brainstem. But I probably will remain unexplained. But the fact that it could be operated on as a hemangioblastoma, you got a complete resection, is going to be very good news for this patient. But these lesions, hemangioblastomas in this area, they're not, I would say, totally rare, and you'll come across them. And the approach to these should be an attempt at complete resection, but bearing in mind the safety of doing surgery in this location, and the fact that these can be very vascular lesions. This one probably wasn't too bad, but they can be, like an AVM almost, trying to remove them. And if you're in the brainstem trying to remove an AVM, you kind of know what you're up against. So you have to be as careful as possible. Use all the tricks and the tools that I was talking about that you used here, and you'll get a good result.
Yeah, the only pre-op considerations they had was they just had atropine ready in the room, and they had defibrillator pads on the patient ready to go.
Great.
Doing some literature review on the transvenous pacing, the biggest drawback, which is, based on your talk, is basically contraindication using transvenous pacing, is that it interferes with the MEPs and SSCPs.
Yeah, that's right. Yeah. Interesting. Well, that's a great case. Thanks, Michael.
Yeah, thank you.
Thanks, Michael. Yeah, great case, good learning point for all of us. And so, let's see if there's any more questions here. Yeah, no. So again, thank you so much. That was a fantastic talk. I think we all definitely learned something from that talk, and there's so much more work to do. But really appreciate your time, Dr. Rucka, and everybody else for their cases. Thank you
Okay,
again,
folks.
and everybody be safe.
Yeah, thanks, everybody. Take care.
Thank you.
See you.